Hello, I am Dr. Thahira Ibrahim, consultant in the Department of Emergency Medicine and Critical Care, Bishop Benziger Hospital, Kollam. I am presenting a respiratory case to help my juniors who are preparing for the coming DNB practical exam. I hope it will be helpful for you. A 75 years old lady presented to our emergency department with a history of breathing difficulty for 3 days, and she was a non-case of chronic obstructive pulmonary disease. Her symptoms worsened today. She was connected to cardiac monitor, pulse oximetry was started, heart rate was monitor showed a heart rate of 132 per minute, blood pressure 200 by 100 millimeter mercury, oxygen saturation was 70% on room air. She was connected to oxygen via non-rebreathable mask, 15 liter O2. Staff were asked to get an IV access, large bore IV cannula. She was kept in propped up position. I started with my primary survey. AIRWAY, it was patent. There was no pooling of secretions, no foreign body, no stridor, no grunting. Breathing part, respiratory rate was 42 per minute. On inspection, there was nasal flaring, use of suprasternal and supraclavicular muscles, no engorged neck veins, no tracheal shift, intercostal and subcostal retractions were there, chest expansion was symmetrical. On palpation, I confirm my inspectory findings, no tracheal shift, symmetrical chest expansion, no tenderness, no subcutaneous emphysema. Percussion, normal resonant node on all areas. Auscultation, it was a silent chest. Saturation, it was 76% on non-rebreathable mask, 15 liter O2. At this point, my interventions were nebulized bronchodilators, non-invasive ventilation, and staff were asked to be prepared for endotracheal intubation. I went on with my primary survey. Circulation, heart rate was 132 per minute and it was sinus rhythm. All peripheral pulses were well felt equally on both sides. Capillary fill time was 2 seconds. Central cyanosis present. Peripheries were warm. Blood pressure was 200 by 100 millimeter mercury. My interventions were large bore IV access obtained and blood sample collected for routine blood investigation. I gave IV corticosteroids. Disability, Glasgow Coma Scale E3, V4, M6. There was no lateralizing signs. Pupil was 2 mm bilaterally equally reacting. Point of care blood sugar was 240 mg per deciliter. On exposure, patient was afebrile and there was no signs of burns, trauma or toxin exposure. I reassessed the vital signs. Heart rate was 140 per minute. It was regular. Saturation was 76% on non-invasive ventilation. Blood pressure was 220 by 120 millimeter mercury. GCS was worsened to E2, V2, M1. So, after reassessing my primary survey, I went on with rapid sequence intubation, 7 Ps. In the preparation phase, airway cart was ready. I assessed the airway of the patient by Lemon score, checked all the equipments, aerosol box was kept ready, difficult airway trolley was also ready, and with all my full personal protective equipment, I approached the patient. A pillow was kept under the oxyput. Pre-oxygenated the patient with non-rebreathable mask, 15 liter O2 for 3 minutes. Pre-medication nebulizations continued. Paralysis, succinyl choline 50 mg IV was given. Under direct laryngoscopy, I visualized the vocal cord and I placed the tube and tube position was confirmed by 5-point auscultation and ETCO2 was 50 millimeter mercury. Tube was fixed at 21 and secured with a tape and ordered for a chest X-ray. Post-intubation, her heart rate was 100 per minute, blood pressure was 130/80 millimeter mercury, oxygen saturation was 92%. ABG showed type 2 respiratory failure. Adjuncts of my primary survey. ECG showing sinus tachycardia with no STT changes. ABG type 2 respiratory failure. Chest X-ray showing emphysematous lung with prominent pulmonary arteries and ET tube in correct place. Screening ultrasound in the emergency department. An A profile and normal lung sliding sign present. Screening echo showed no RWMA, original wall motion abnormality. Riles tube was inserted and Foley's catheterization done. Then I reassessed my primary survey. Airway was secured with endotracheal tube. Breathing, intubated and connected to ventilator. Saturation was 96% on FiO2 60% and minute ventilation was 8 ml per minute. Nebulizations were continued. Circulation heart rate was 100 per minute. Blood pressure 130 by 100 mm mercury. Cardiac monitoring continued. Disability GCS, E3, VT and M5. After my primary survey, my differential diagnoses are acute exacerbation of chronic obstructive pulmonary disease or asthma, acute respiratory distress syndrome or sepsis, acute left ventricular failure, fluid overload, pneumothorax, and toxins. I went on with my secondary survey. Signs and symptoms, sample history, signs and symptoms. She was having breathing difficulty for 3 days. She took self-treatment at home with nebulizations and inhalers. Symptoms worsened today afternoon, so she came here. She was not able to lie down or sit comfortably. No history of chest pain or reduced urine output. No history of fever. History of dry cough for last 1 month. And there is no history of contact with COVID-19 positive patients. Allergies. No history of any drug allergy. Dust allergy was present. Medications. She was on formoterol and budesonide inhaler, metformin and Cilacar. Past history, she was a non-case of chronic obstructive pulmonary disease with recurrent exacerbations and admissions. Last admission was 7 months back. She was a non-case of diabetes mellitus and hypertension on treatment. Her last meal was 4 hours back. And events, she was a homemaker who is a non-case of chronic obstructive pulmonary disease. She developed symptoms for last 3 days and exacerbated today afternoon. So she came to my hospital. General examination. Central cyanosis was there. Bilateral pitting pedal edema present. No pallor, no icterus, no lymphadenopathy. Weight was 60 kg. Pulse 132 per minute. Regular in rhythm, normal character and volume, no radiofemoral or radioradial delay. All peripheral pulses were well felt equally on both sides. Blood pressure was 130 by 100 mm mercury on the right arm. Saturation was 96%, respiratory rate of 12 per minute. Head-to-toe examination, head, eyes, ear and throat examination was within normal limit. Patient was intubated, airway intubated. Chest examination, trachea was central, no engorged neck veins, no visible scars, symmetrical chest expansion, work of breathing increased, no chest wall deformity, resonant not on percussion, normal resonant not on percussion, air entry reduced bilaterally. Cardiovascular system examination, no engorged neck veins, no visible pulsations, apex beat was felt in left intercostal space. 1 centimeter lateral to the mid-clavicular line. No thrill, loud P2, no murmur. Abdomen and pelvis examination. It was a scaphoid abdomen with no scars, no visible peristalsis, non-tender, no organomegaly, no guarding or rigidity, bowel sounds normal, normal resonant not on percussion. Liver dullness was present. Liver dullness in the normal space. Felt in the normal space. Central nervous system examination. GCS, E3, VT, M6. There was no lateralizing signs. Pupil was 2 mm bilaterally equally reacting and Richmond-Alman sedation scale was 0. Investigations. Total count was 14,000 with neutrophil predominance. CRP was 18. Troponins were normal in normal limits. RFT, LFT with normal levels. Serum electrolytes normal. urine routine examination was sent, blood culture was sent, serum calcitonin level was sent, echo showed right ventricular enlargement with EF, ejection fraction 45% and no regional wall motion abnormality. Diagnosis. So for my primary and secondary survey, my diagnosis is a 75 years old lady with acute exacerbation of chronic obstructive pulmonary disease in type 2 respiratory failure with features suggestive of right heart failure. Management. Patient was connected to ventilator, SAMV PRVC mode. Ventilator settings are FiO2 adjusted according to saturation. Tidal volume was 420. Respiratory rate was 12 per minute and P5. IE ratio of 1:2. ABG was repeated after 15 to 30 minutes after intubation. It was showing an pH of 7.12, PCO2 reduced to 100, PO2 66 and bicarbonate 27. Patient was admitted in the ICU and gave handover to the ICU in charge by the mnemonic ISBARQ, identification, situation, background, assessment, remediation and any questions. A few words about Richmond Agitation Sedation Scale. This is from Rosen's textbook of emergency medicine. +4, +3, +2, +1. Usually sedation is, this is for sedation in a ventilator, requirement of sedation in a ventilator patient. Sedation is recommended, deep sedation is recommended from +1 to +4 scale. And 0 to -4, there is no need for sedation. This is about Richmond Agitation Sedation Scale. And type 2 respiratory failure, you all know there will be hypoxia, hypercarbia and respiratory acidosis. So thank you all. Stay safe. If you have any questions or controversies regarding my presentation, please feel free to inbox me, email thahira28@gmail.com. I'll try to remediate it. Thank you all. Thank you.